Alright. Welcome to NeuroClarity, the podcast that turns neurologic miseries into memorable moments. I am Onowori Victor, your host, and today we are going deep into three neurological cases to teach you how to localize like a neurologist. Our cases are derived from Ching and Cheng's comprehensive review of clinical neurology, and we are currently in chapter 2. We are doing questions 31 to 33. Whether you're a student, a resident, or just curious about how to make sense of the brain and nervous disorders, this episode is for you. Let's get started with our first case. Question 1. A 57-year-old man presents with acute onset of dysarthria, paralysis of the right arm and leg, sparing the face, and loss of position and vibration sensation on the right side of the body. On examination, it is also noticed that the tongue deviates to the left. Which of the following is the most likely diagnosis? A. Right lateral medullary syndrome. B. Left medial medullary syndrome. C. Right medial medullary syndrome. D. Right pontine infarct. And E. Left lateral medullary syndrome. What do we think? Now, for cases like this, I like to analyze the question. So basically, we are given a 57-year-old man, and we're told that he presents with sudden slurred speech, what we call dysarthria. He has paralysis of the right arm and leg, but hold on, his face is spared. He also has loss of vibration and position sense on the right side of his body. On examination, we are told that his tongue deviates to the left when he sticks it out. Let's break this down. First, what's dysarthria? Dysarthria means slurred or unclear speech due to weakness or discoordination of the muscles that control the tongue, lips, or voice box. The thinking is fine, but the motor control for speaking is impaired, and this is common in strokes. Now, let's analyze our clues. We're told that 1. This patient has right-sided paralysis. The arms and legs are gone, but the face is spared. 2. This patient has right-sided loss of vibration and position sense. And 3. There's tongue deviation to the left. To localize this, we need to understand how motor and sensory signals travel in the central nervous system. Motor pathways like corticospinal tract start in the brain and cross over at the lower part of the medulla, and that is what we call the pyramidal decussation. So a lesion above the decussation, like the left medulla, will cause weakness on the right side of the body. Sensory pathways for position and vibration travel through the dorsal columns. They ascend the spinal cord and also cross over in the medulla, joining the medial lemniscus. So, damage to the left medial medulla would explain the right-sided weakness from corticospinal tract injury and the right-sided vibration stroke position loss from medial lemniscus injury. Finally, the hypoglossal nerve is injured. The hypoglossal nerve actually controls the tongue movements. Hypoglossal nerve is cranial nerve number 12. It exits from the same side of the medulla, and when it's weak, the tongue deviates towards the lesion, in this case, the left. Always remember, the tongue never lies. To wrap this up, all these signs point towards one syndrome, and we call that the left medial medullary infarct. Fun fact, this is also known as the Dejerine syndrome and is usually caused by occlusion of the anterior spinal artery or the medial branch of the vertebral artery. Was that too much for you? I guess not. Let's do a little recap. Localizing medial medullary syndrome. You see contralateral arm or leg weakness? Think corticospinal tract. You see contralateral proprioception or vibration loss? Think medial lemniscus. You see ipsilateral tongue weakness? Think hypoglossal nerve. What strikes your mind? Left medial medullary syndrome, aka the Dejerine syndrome. Easy, right? Next question. Question 32. A 65-year-old woman went on a roller coaster ride. About 3 weeks later, she had an episode of what sounds like amaurosis fungaris in the left eye. She also complains of headaches, feels weak all over, and states that her shoulders have been aching for at least 6 months. She also reports that when she's eating, she gets tired of chewing and her jaws hot. Initial non-invasive imaging studies of the brain and intracranial and extracranial circulation are unremarkable. Besides checking an ESR, which of the following is the next best step? A. Cerebral angiogram. B. CT angiogram of the neck. C. Start heparin and bridge to warfarin. D. Schedule a temporal artery biopsy. And E. Start steroids. Yeah, so what do we think? Like we always do, let us analyze the question. We are told that we have a 65-year-old woman who went on a roller coaster ride. 3 weeks later, she experienced sudden vision loss on her left eye, like a curtain coming down. Her imaging is unremarkable. She also has new headaches, chronic shoulder pain, and she says her jaws get tired and painful when she chews. Let's unpack the story. That vision loss sounds like Amaroctis fungus, which is a brief, painless blackout of vision in one eye caused by temporary lack of blood to the retina. Think of it like a warning mini stroke in the eye. Her jaw claudication, which is pain or fatigue while chewing, is a huge clue. It suggests ischemia of the jaw muscles supplied by the superficial temporal artery, which is a branch of the external carotid artery. Add in the new onset headache, scalp tenderness, constitutional symptoms, and proximal muscle pain in the shoulder, and this becomes a classical textbook case of GCA. GCA? Giant cell arteritis. Giant cell arteritis is also called temporary arteritis, and it is an immune-mediated vasculitis affecting large and medium arteries in adults over the age of 15. The arteries become inflamed and narrowed, risking permanent blindness if the ophthalmic artery is affected. Laboratory clues includes very high ESR and elevated CRP, that is, erythrocyte sedimentation rate and C-reactive protein. But when there are visual symptoms, do not wait for results. It's important for you to note, if you suspect giant cell arteritis, start high dose corticosteroid immediately, even before a biopsy. Why? Because delay can lead to permanent vision loss. A temporary artery biopsy is done later to confirm the diagnosis. And what will you see? Basically, you see what is called a granulomatous inflammation with giant cells. Quick recap. The temporary artery is in trouble if you see Amaroctis fungus, a fancy name for transient retinal ischemia, jaw claudication, which is ischemia of the mastication muscles, the muscles for chewing, in a patient who is above the age of 50 with new onset headaches, scalp tenderness, and shoulder pain. These are classic signs. Don't delay, don't wait for a biopsy, start steroids immediately, and then you can think biopsy. Think giant cell arteritis. That wasn't so hard. On to our next question. Question 33. A 49-year-old woman presents with acute onset of left hemiplegia and right-sided facial weakness involving the upper and lower facial movements. Which of the following is the most likely diagnosis? A. Right pontine infarct. B. Left pontine infarct. C. Right midbrain infarct. D. Left midbrain infarct. And E. Right MCA infarct. As always, let us take a look at our story. So we're told that we have a 49-year-old woman who can't move her left arm and legs. This occurred suddenly. She also has right-sided facial weakness involving the upper and lower face. Let's pause right here. When you hear full facial weakness, including the forehead, that tells you that it is a lower motor neuron facial palsy. In fact, there's a fancy mnemonic for this. Upper space upper, lower takes all. In other words, if you have an upper motor neuron lesion, you're not going to have an upper face paralysis. But if you have a lower motor neuron palsy, it takes all. It takes both the upper and the lower face. Now, she has 1. Left-sided hemiplegia and 2. Right full facial weakness. That means the body is weak on the opposite side of the brain lesion, which indicates corticospinal tract involvement before the dissociation, and the face is weak on the same side of the lesion, meaning the facial nerve nucleus or fibers have been involved. That's classical for a pontine lesion, specifically on the right side, and there's a fancy name for this syndrome called Millard-Gubler syndrome. In Millard-Gubler syndrome, there is lesion in the ventral pons, and this involves the corticospinal tract causing the contralateral hemiplegia and the facial nerve, cranial nerve number 7, causing ipsilateral full facial palsy. So, the clue is in the face. Once you see contralateral hemiplegia and ipsilateral full facial nerve palsy, think right pontine infarct, and think Millard-Gubler syndrome. Let's wrap things up. Today, you learned how to crack three powerful neurology cases by following anatomy and patterns, whether it's the twisted tongue of the medulla, the silent thief of vision in giant arteritis, or the split face stroke of the pons. Localization is the name of the game. Remember the following, and localization becomes like 2 plus 2. 1. Ask the question, where is the weakness or sensory loss? 2. Ask yourself, is it crossed? Usually, that means a brainstem issue. 3. Add cranial nerve findings, and hola, you've gotten your lesion mapped. If you found this episode helpful, you can subscribe, share, like, or give us a comment down in the comment section. Until next time, stay curious, stay sharp, and keep seeking your clarity. Bye for now.